Now, this 10 years old child was playing in the street with sharp sticks as swords with other children, and one child poked it in his right eye. Few days back, first few days he was able to see, so couldn't complain to parents, and now presented with hand movements, vision, full thickness corneal tear, traumatic cataract with ruptured anterior capsule. B scan is normal, retina is attached. Now he had a bad chest, and already few days were passed. Child seemed cooperative, so I performed biometry of the other eye and decided to perform his corneal tear plus cataract extraction in local anesthesia. Patient selection is very important, so I injected 3 cc local anesthetic peribulbar. Remember, if a child allows you easily to inject peribulbar block, now that's a hint that you can perform his surgery as well in local anesthetic. Another important tip is always prepare cutter in a ruptured anterior capsule with traumatic cataract. You don't know whether PC is intact or not. So I made main port with the 2.75 knife, put viscoelastic, deepened the anterior chamber, and also with gel cannula broke the iris and corneal adhesions while injecting gel. And then here you can see with the dialer again I made sure that corneal wound is away from the iris and lens. Now I am sealing the corneal wound with the two 10-0 nylon interrupted sutures. Now these sutures are their alignment is very important. Make sure take a bite 2/3 deep in a corneal stroma, in a healthy corneal stroma, and come out exactly same distance on another side with same depth, and sutures should be on the tighter side. At this time, up till this time, the patient is extremely cooperative, and my plan is to first seal the corneal wound and then proceed towards cataract surgery. And now you can see that we are completing the first corneal suture, and now here I am burying the corneal suture and now cutting the ends, and now the second suture. Now I am applying the second suture. Now the wound was such that two parallel sutures are more than enough to completely seal the corneal wound, the corneal defect. You can see how you have to pass into the cornea. Now both sutures are equidistant, equal in length, and they are parallel to each other. So that's how you apply stitch. I have showed you the whole process of applying suture. Now I'm burying it, and now cutting the ends. So after corneal wound repair, now I am removing the gel from the anterior chamber and also aspirating the lens matter displaced in the anterior chamber. And here I am also making sure that the corneal wound, the sutures are only in the cornea, and no part of iris or anterior capsule is entangled. And now I am putting the trypan blue dye to stain the ruptured anterior capsule. Remove the dye with the Simcoe cannula. Now at this time again the patient cooperation was exemplary. Now I'm putting the viscoelastic and I thought that I am near the completion of this case and the patient is very cooperative. Now with the cystotome I am trying to perform capsulorhexis, but there were many cuts in the anterior capsule, so I was not able to perform capsulorhexis. I was content with capsulotomy in this case because the patient is 10 years old child, lens is very soft because its cataract is formed due to trauma. So lens matter aspiration can easily be done in a torn capsule, but we should make sure that we didn't entangle the capsule edges in the Simcoe cannula while aspirating the cataractous lens. So I performed large capsulotomy and I thought that I am about to finish the case, but as soon as I removed the inferior lens matter and the nucleus, I was feeling resistance to the aspiration of the lens matter and the anterior chamber became uneven deep inferiorly. So I thought that something is wrong and I saw posterior capsular rent. So trauma had caused ruptured not only in the cornea and the anterior capsule but also posterior capsule of the lens inferiorly as well. It was a inferior circular PCR. So I stopped further aspiration, gently came out, put viscoelastic, made side port and entered the cutter through main port and irrigation and cannula through side port as you can see, and started anterior vitrectomy. Now here I forgot to stain the vitreous with triamcinolone because as we are making this video from Android phone and not through microscope, so there is no red reflex and you are not able to appreciate it, but here you can see that the dark inferior dark oval area, that is the PCR. So first cut the vitreous at the wound, then in the anterior chamber, but quickly proceed the cutter in the bag in that rented area and then put the cutter past the posterior capsule in the anterior vitreous and start vitrectomy. Now that's the ideal technique to remove vitreous behind the lens. So there is no vitreous behind the lens to prolapse in the anterior chamber, and if you do this and there is less chances of enlarging the PC rent. So after making sure that all the vitreous in the anterior chamber as well as behind the PC is removed, I came out, put viscoelastic and started removing the remaining cortical sheets, and now you can see that I have removed almost all the cortical sheets. First I removed the superior cortical sheets from the side port and now from the main port. You can see that the pupil is circular. Now I'm putting viscoelastic because while removing the cortical sheets again some vitreous from the anterior vitreous came in the anterior chamber. So again you can see that I am cutting and you can clearly see that the tip of the cutter is in the anterior vitreous. So that's the ideal technique in order to avoid enlargement of the PC rent that do the anterior vitrectomy in the anterior vitreous instead of in the anterior chamber. In the anterior chamber there will be the pull of vitreous and it will enlarge the PC, and you may also remove the whole bag. So always perform vitrectomy in the anterior vitreous rather than in the anterior chamber. So now again I have removed the prolapsed anterior vitreous. I came out. Now put viscoelastic to maintain the anterior chamber, but now I will not because there is inferior PCR, so I will not put the foldable IOL, but instead I will implant large 6.5 IOL in the sulcus. That's why I have enlarged the 2.75 wound up to 6 millimeter with the help of the same 2.75 phaco knife sideways. And now you can see that I have easily put the IOL into the anterior chamber, and now with the help of a dialer I will dial the IOL in the sulcus. Now here again your movements are very important. You should make sure that your visibility is very good and you are implanting the IOL in the sulcus, because inferiorly there is no support. So if somehow you implant the IOL in the back, there are chances that the IOL can tilt and it can also fall into the vitreous. So make sure that you are above the anterior capsule. And the good thing about the sulcus IOL is that it has got a very large haptics, and once you fix the haptics in the sulcus, and if the lens, if IOL is there in the sulcus till the end of the surgery, chances are very remote that it will fall off. So now you can see that the pupil is round and IOL is in the sulcus. So now just one stitch, as we have made the wound with a phaco knife, so it is a step incision, and one stitch in the center of the wound is enough at 12 o'clock to seal the corneal wound. So 110 nylon at 12 o'clock, 210 nylon to seal the corneal tear defect. Now at this point the patient got irritated, but he was justified, because we were not aware of that PCR, that it will take that much time. So he was again and again raising his hands and started crying, but we are calming him down that your surgery is almost finished. At the end, I injected intracameral moxifloxacin and air to confirm no vitreous is in the anterior chamber. So it was a very challenging case with a 10 years age patient, corneal tear, traumatic cataract, ruptured PC, vitreous prolapse, and a bad chest, and I performed it successfully in local anesthesia. Thank you very much.